Hi, everybody. This is Professor Mulcahy. We're going to talk about some things that happen before conception. That's our first week's class. This covers contraception and family planning. It covers fertility, infertility, preconception counseling, and genetics. Very, very brief intro to genetics. We are not delving into that topic extensively. It's just too much. So here are our objectives. We compare the different forms of contraception available and identify the considerations that go into family planning. We're going to discuss the different kinds of fertility and infertility care, discuss preconceptual counseling and who benefits from that, and we're going to identify some patients who would benefit from genetic counseling. So just to introduce the topic of contraception generally, the World Health Organization and the CDC both have identified access to contraception as a public health goal because it is important in increasing the quality of life for men and women. It increases educational and economic opportunity for both men and women, which makes sense. If you can plan your families well, you can maximize your opportunities, and people who have unintended pregnancies get waylaid in terms of their professional and personal goals. It reduces maternal and infant mortality and morbidity by allowing for control of pre-existing conditions prior to a pregnancy. When pregnancies are spaced more than 2 years apart, outcomes are better for both mom and baby, so we can space our pregnancies more optimally. It reduces stress on families. If every child that is born is a child that was planned, obviously there's going to be less financial stress, less emotional stress, and it prevents unsafe abortions in parts of the world where legal safe abortions are not protected. So when we're getting into a conversation about which method is the best method, there is no one-size-fits-all answer here. The best method is the one the patient has access to, can afford, will tolerate, and will use. The number one reason for contraceptive failure is user error or failure to adhere. The rate for continuation of a method is actually pretty low. Some people will try something. Most people within a year have decided to discontinue that method and either try something else or leave it up to chance, which is not ideal. Methods that take user error, the less the patient has to do to promote contraception, the lower the failure rate. So for some people, the best methods are more long-acting, either long-acting reversible contraception, what we call LARCs, or permanent sterilization, a tubal ligation for women and a vasectomy for men, depending on whether or not they want children in the future. Only condoms prevent infection while preventing pregnancy. At every single visit, a woman should be asked, or, men should be asked too what their plans are, but because women get pregnant, we're going to limit the discussion to them. What are your plans for having children? Do you plan to become pregnant in the next year? If they say no, then the conversation needs to turn to what contraception are you using? If they are not using a method, or they are using a method that is less effective, then we need to open that conversation. If they say that, yes, they would like a pregnancy within a year, then we have to turn our conversation over to preconception planning. What are you doing to get healthy, to have the best pregnancy you can? So it has to be consideration, no matter what setting they come to care for. As we move through the content, I want you to think about individualizing your care. So think about all these considerations. Some people have relationships with people. They maybe have a source of conflict over whether or not to have children at the moment. So they don't want their partners to know they're using it. Or maybe they want their partner to use a condom and they don't want their partner to know that they're also protected from pregnancy by some other method. Some women don't like touching their bodies, so a method that involves inserting something into the vagina would be inappropriate for them. Some people would like to get pregnant in the next 3 years. We're not going to steer them towards a LARC. Some people would be devastated if they got pregnant within the next 3 years. LARCs are perfect for these people. Some people might not have access to see a provider very often. So maybe we want to steer them to methods that are easy to obtain from a pharmacy. Don't require a prescription, don't require an annual visit. Some people don't have insurance, so you don't want to give them a method that's going to cost $1,200 initially. And some people are done having families altogether, and those people would need something a little more permanent. So think about all those considerations. And we're going to launch right into the hormonal method. It'll make this video a little bit longer, but that's okay. Hormonal methods are very popular. They, in theory, are very effective. However, user error again, number one thing. We have pills, patches, shots, rings, and implants. These work by suppressing ovulation. That's the number one mechanism. So there's no egg available for fertilization. They also make everything sort of inhospitable for pregnancy. They disable sperm by thickening the cervical mucus. They can't swim up through the canal to the fallopian tubes where fertilization happens. They thin the uterine lining so that if there were a fertilized ovum, it could not implant. How effective are they? Well, in a perfect world, fewer than one person out of 100 would get pregnant in a year, but in reality, it fails 3 to 8% of the time, depending on the method, sometimes up to 9%, sometimes higher. And we'll kind of go through the individual methods. There are a lot of advantages to hormonal methods. There's no effect on future fertility. It doesn't impact spontaneity. And then it has all these sort of off-label uses, like relieving PMS, lighter periods, no cramping. It reduces acne in some cases. And you see that more with the combined methods. Disadvantages, they need a prescription. Some people are getting around this now that COVID has hit. One of your hot topics was contraceptive deserts. Some people don't live near a provider, and with COVID, some people might live near a provider but are unable to get to it or don't feel comfortable waiting in a waiting room. So you can get this sort of mail order thing where they have a doctor on call who will do a screening over a phone or, telehealth appointment. But you do need a prescription to obtain them. They are not effective against sexually transmitted infections. So if that is a risk factor, the patient needs to use a condom. Side effects, just like early pregnancy, you get nausea, breast tenderness, mood swings. You can get weight gain, you can get headaches. And the progestin methods tend to promote irregular bleeding. In the beginning, the bleeding tends to be a little bit heavier, a little less predictable. And then it sort of lightens up and sometimes disappears. The big adverse reaction, and this is a testable concept, you could tell because I put it in exclamation point and all that stuff, are the blood clots. DVTs happen. Now, I'm going to have you keep in mind that a pregnancy for most age groups, for women under 35, actually is a higher risk for blood clots than hormonal methods. But we still don't want to give them to anybody who has a history of a DVT, PE, stroke, any kind of blood clotting disorder. We don't want to give them to smokers over 35. It's also contraindicated for women with migraine, with aura, and hypertension. The combination methods are not for breastfeeding mothers. The Progestin-only are a choice that they can use. I'll get into that in a minute. So we have combined pills, the estrogen-progestin combination. Generally, you have 21 pills in a pack, and then you have 7 pills. They might be a little different color. They look a little different. They're just to keep the woman in the routine of taking a pill every single day, so that she doesn't forget and doesn't have to remember, oh, it's Tuesday, it's time to start a new pack. There are also methods. Seasonal is the one that I'm familiar with, 84 pills. So you get 3 months without any kind of vaginal bleeding. Until that 7 days of placebo, you get a little withdrawal bleeding. So they only get really 4 periods a year, and they're usually very light and they don't last very long. The combined pills are actually used for off-label things, polycystic ovarian syndrome, which is an imbalance of hormones, an excess of male hormone. The combination pills relieve that. People with severe acne sometimes benefit from a combined pill. Menstrual cramping, heavy bleeding, because all of that is lighter. The big take home, when you send somebody home with oral contraceptives, if you miss a dose, and this is combined pills, not Progestin-only, we're going to see that in a minute, take the pill as soon as you remember. So let's say you ran out the door, you were running late, and you forgot to take your pill, and now it's 2 o'clock in the afternoon. Oh no, I forgot to take my pill. Well, as soon as you get home, you take that pill. Then you take the next dose at the regular time. You're still considered protected if it's only one. If you miss more than one, take the next dose when you remember. Take the next scheduled dose after that, but use other birth control for 7 days. This is not a great method for people who tend to be forgetful, people who work like swing shifts. This week they're on days, that week they're on nights, they forget. Failure rate in reality is 9%, even though it's less than 1%. If you do it perfectly, no one's perfect. After the combined methods, we have progestin-only pills. These have no estrogen component. They're safer for breastfeeding mothers. Some of them, some people will say that they reduce the milk supply, but in the literature that is not supported. All 28 pills in a pack contain progestin. There are no placebo pills. This is the big thing. If you miss it by 3 hours, all protection goes out the window. So if you normally take it at 7 and now you sleep in and it's 10:30, you have to use a different method for the rest of the cycle. Primary side effect is a less regular period and more breakthrough bleeding. Taking a pill every single day. There's no withdrawal week. And if pregnancy does occur, when we get to pregnancy, you're going to see progesterone slows everything down. Progestin slows the cilia in the fallopian tube. Like there are these tiny little muscle contractions that help the sperm up the fallopian tube where it meets in the ampulla for the egg. If pregnancy does occur, it's more likely to be ectopic. Okay, and we have rings, little flexible silicone rings. I'll have pictures of all these up for you guys. They are a combination method. They have estrogen and progestin. Ring goes in the vagina for 3 weeks, comes out for a week to create a withdrawal bleed, and then you replace it with a new ring. Can be removed for intercourse and left out for 3 hours per day, but you want to get that back in. Placement in the vagina is not important. Can be dislodged during a bowel movement. Women should teach, and this is where you get sometimes people reluctant to do this. Every time she has bowel movement, she should check the placement of the ring, check the toilet, make sure it didn't end up there. Not a great method for women who are not comfortable with their own bodies. And then we have patches. There's similar to any other patch, nicotine patch, fentanyl patch, anything. Has estrogen and progestin applied weekly for 3 weeks. So you rotate the sites to from the upper back, upper arm, upper buttock, lower abdomen, never on the breast. Less effective when the BMI is greater than 30. Estrogen is stored in body fat, and when you're delivering this as a subcutaneous delivery, sometimes the estrogen doesn't get into the systemic circulation. So the failure rate with normal BMI due to user error is 9%. This is realistic use, not perfect use. But when we have women who weigh more than 198 pounds or have a BMI greater than 30, those rates go up, and they are sort of connected to the actual body weight. It is not a good method for breastfeeding mothers. The estrogen will get into the breast milk. It is not good for the baby. We have injections. There's Depo-Provera. We see this a lot on postpartum. We send them out with a Depo-Provera shot. It is a progestin-only method. It is good for 13 weeks. Failure rate of 6%. Again, this is usually because people miss their appointments to get the next injection. Optimally, you want to make sure that she starts it within 7 days of the start of her last menstrual cycle. If that's not feasible, give a pregnancy test first. You do not want to give Depo if the woman could possibly be pregnant. It can impact pregnancy. Concerns include weight gain. Some people get headaches. And then there's irregular bleeding. Often beginning with Depo, you might get your period a little bit longer or a little bit heavier. Eventually they get lighter and they may even disappear, so women don't get periods at all. And for some women that's concerning because they think they're pregnant. But some women find that to be an advantage. It can be used with breastfeeding mothers. The anecdotal reports not supported in the literature that it may diminish milk production. That is something I've heard from lactation consultants, but in the literature it does not support that. Hormone-containing birth control, we have the contraceptive implant. These look like little rods that are implanted under the skin. They are tiny and flexible, and they release a progestin it's ethanogestrel. It's similar to what Mirena has. Mirena is an IUD. We'll talk about that later. It's in the inner upper arm. So it must be done by a licensed provider in an office, approved for use for 3 years. So it provides 3 years of protection. So if you have somebody who is finishing their education, they absolutely cannot become pregnant in the next 3 years. That is not something that they want. There is no user error. It's actually a good method. You can get some unscheduled bleeding, but it's usually very light. A majority of women go right back to fertility within a month of removal. Here's the problem. The removal process is not as easy as the insertion process. And sometimes women get scars, or sometimes it's hard for them to get the rods out. So that's a consideration, but it is a very, very good method. It's actually more effective than having your tubes tied. And that is your implant. Then we have emergency contraception. Now, this is sort of a controversial area for some people. It shouldn't be, but it is. This is what's known as the morning after pill. There are 2 ways that you can provide emergency contraception. One is an oral medication. The second is by implanting the Paragard, which is a copper IUD. For the hormonal contraception part of it, the pill, there are 2 options. One's over the counter. It's known as Plan B. Levonorgestrel, which is a progestin, works by preventing ovulation. It is most effective when taken within 72 hours. It does not affect if you were already pregnant when you had the unprotected sex. It will not affect the pregnancy, but it must be used within 72 hours of unprotected sex. There was a lot of controversy when it went over the counter because people felt that it should be limited or regulated. But some women won't go to a provider, and some women don't have access to a provider. Some pharmacies were refusing to carry it. But that is Plan B. Then we have Ella, or ulipristal. It's available by prescription only. You get a bigger window. It's 120 hours within 120 hours of unprotected intercourse. It's a progestin blocker. It may affect an existing pregnancy. Side effects with these, you get really severe nausea sometimes. It's like taking a lot of birth control pills at once. And that's your hormonal methods. And we will quit here for a second and pick up with barrier methods.